hard to define in these times, but I got nothing but love on my mind. I need a baby while I'm in my prime. Need an adversary to my down and weary. Like, tell me that's life when I'm stressing at night. Be like, you'll be okay and everything's alright. Let me in nothing cause I'm not wanting anything but your love in your body and a little bit of your brain. These days are way too lonely. I'm missing out, I know. These days are way too long, and I'm not forgiving love away, but I want someone to love me. I need someone who needs me, cause it don't feel right when it's late at night and it's just me and my dreams. So I want someone to love. That's what I fucking want. I want someone to love me. I need someone who needs me, cause it don't feel right when it's late at night and it's just me and my dreams. So I want someone to love. That's what I fucking want.
1, 2, 1, 2, 3.
Oh yeah, yeah. Oh yeah, yeah, yeah. Ooh. Oh yeah, yeah. Oh yeah, yeah, yeah. Ooh. Never had much faith in love or miracles. Ooh. Never wanna put my heart on the line. Ooh. But swimming in your water, something spiritual. Ooh. I'm gonna get every time you spend the night. Cause your sex takes me to paradise. Yeah, your sex takes me to paradise. And it shows. Yeah, yeah, yeah. Cause you make me feel like I've been locked out of heaven for too long. For too long. Yeah, you make me feel like I've been locked out of heaven for too long. For too long. Oh yeah, yeah, yeah. Ooh. Oh yeah, yeah. Oh yeah, yeah. Ooh. You bring me to my knees, you make me testify. Ooh. You can make a sinner change his ways. Open up your gates, cause I can't wait to see the light. Ooh. And right there is where I wanna stay. Cause your sex takes me to paradise. Yeah, your sex takes me to paradise. And it shows. Yeah, yeah, yeah. Cause you make me feel like I've been locked out of heaven for too long. For too long. Yeah, you make me feel like I've been locked out of heaven for too long. For too long. Can I just stay here? Spend the rest of my days here. Can I just stay here? Spend the rest of my days here. Cause you make me feel like I've been locked out of heaven for too long. For too long. Yeah, you make me feel like I've been locked out of heaven for too long. For too long. Oh yeah.
I wanna follow where she goes. I think about her and she knows it. I wanna let it take control. Cause every time that she gets close, yeah, she pulls me in enough to keep me guessing. And maybe I should stop and start confessing. Confessing, yeah. Oh, I've been shaking. I love it when you go crazy. You take all my inhibitions. Baby, there's nothing holding me back. You take me places that tear up my reputation, manipulate my decisions. Baby, there's nothing holding me back. There's nothing holding me back. There's nothing holding me back. She says that she's never afraid. Just picture everybody naked. She really doesn't like to wait. Not really into hesitation. Pulls me in enough to keep me guessing. Oh, and maybe I should stop and start confessing. Confessing, yeah. Oh, I've been shaking. I love it when you go crazy. You take all my inhibitions. Baby, there's nothing holding me back. You take me places that tear up my reputation, manipulate my decisions. Baby, there's nothing holding me back. There's nothing holding me back. Cause if we lost our minds and we took it way too far, I know we'd be alright. I know we would be alright if you were by my side. And we stumbled in the dark, I know we'd be alright. I know we would be alright. Cause if we lost our minds and we took it way too far, I know we'd be alright. I know we would be alright if you were by my side. We stumbled in the dark, I know we'd be alright. We would be alright. Oh, I've been shaking. I love it when you go crazy. You take all my inhibitions. Baby, there's nothing holding me back. You take me places that tear up my reputation, manipulate my decisions. Baby, there's nothing holding me back. Oh, there's nothing holding me back. I feel so free when you're with me, baby. Baby, there's nothing holding me back.
Feeling my way through the darkness, guided by a beating heart. I can't tell where the journey will end, but I know where to start. They tell me I'm too young to understand. They say I'm caught up in a dream. Well, life will pass me by if I don't open up my eyes, so that's fine by me. So wake me up when it's all over, when I'm wiser and I'm older. All this time I was finding myself and I didn't know I was lost. So wake me up when it's all over, when I'm wiser and I'm older. All this time I was finding myself and I didn't know I was lost. get the chance to travel the world, but I don't have any plans. Wish that I could stay forever this young, not afraid to close my eyes. Life's a game made for everyone, and love is the prize. So wake me up when it's all over, when I'm wiser and I'm older. All this time I was finding myself, and I didn't know I was lost. So wake me up when it's all over, when I'm wiser and I'm older. All this time I was finding myself, and I didn't know I was lost. I didn't know I was lost.
Hi, Caroline.
Sorry, I'm not very good at Zoom.
No, it's okay. Don't worry at all. We are still waiting for some participants, so yeah, it might take
Yeah,
like 5 to 10 minutes if it's okay.
that's absolutely fine.
Okay, thank you very much. So, how are you?
I'm good. I'm just trying to turn on my video. I don't know if that's working.
Yes, you did it.
Oh, there we go. Brilliant. Fabulous.
Just wondering, do you want to have like a background like mine?
I got I think I've just got a bike, don't I?
Yeah, you got it.
I mean, if you I don't know if I can put a background like yours on.
I mean, if it's okay also to use the bike.
Virtual backgrounds. I've got like no options.
I can send you through email.
Yeah, sure. Okay, if you send it to me through an email.
Okay, perfect.
Oh no, that's just going to make me have like a cat face or something. I was about to turn something else on. I was like, no, that doesn't look right. Sure, if you send me your send me that one.
Okay, got it.
How do I make this not full screen? There we go. Right, okay.
Just email it to you.
Thank you.
No worries.
I'll try to do the authenticator thing. There we go. That worked. You're muted.
Yeah, it works perfect.
Great. Okay. I just close that, do I? That goes. Oh, no, where is that?
Okay, people are coming, so let's just wait for 5-10 minutes then. Selamat siang, Prof. Revi.
Yo, selamat siang. Tuh.
Yeah, so Caroline, this is the Dean of Faculty of Medicine, Prof. Reviono. And Prof. Reviono, this is one of my lecture during my studies, Dr. Caroline Copeland.
Nice to meet you. Hi.
Yeah. Okay, nice to meet you too.
Oh, there we go. I can take the major's biology off my name, can't I? There we go.
Okay.
Right. So do you normally do sessions on a Saturday? Because it's a Saturday afternoon with you, isn't it?
Yeah, now it's Saturday afternoon.
Do you normally do like sessions on a Saturday?
We kind of do because, to be honest, sometimes during like what is it, Monday to Friday, it's like full book of college. Like students have their tutorials, case lab, clinical rotation, and stuff. So it's kind of hard to put this kind of things on those days. So that's why we usually did it on Saturday.
Okay, fair enough. I'm very impressed with your dedication.
Thank you. I'm so also like happy. I mean, like you're willing to do this on Saturday. I'm so like appreciate it.
Not a problem at all. It's so early here as well.
Yeah, I believe so.
Well, it's not that early, but it's early enough in the day. There's absolutely no problem.
Yeah, it's still early. I mean, usually we are start like at 9, right? I mean, in the
yeah. Yeah. Have the marks been released to you yet?
Yeah, absolutely. The mark has
Oh,
been
you did?
released. Sorry?
Oh, brilliant. When were they released?
They have released all the mark, including like the dissertation and stuff, but they have not released in the transcript.
Oh, so you haven't received like your final degree?
No, yeah, so,
Okay.
not yet. So they still have not released 2 marks for the clinical one.
Okay, fair enough. I think we had the exam board earlier this week, so you should be hearing probably early next week.
Hopefully.
So.
I hope so. Okay, people are starting to coming. Maybe we will start in like 2 minutes.
Yeah,
If that's
fine.
okay.
Yeah. Will I be able to share my screen? Yeah, so, oh no, you cannot. Okay, right.
Okay, we will start.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone, and good morning for those who are in London. Welcome to our first series of International Guest Lecture. My name is Camila, and I will be your MC for today's event. I would like to personally welcome to Honorable Prof. Reviono as Dean of Faculty of Medicine, Sebelas Maret University. I would like to welcome our honorable speaker for today, Dr. Caroline Copeland from King's College London. It is a pleasure to have you joining us today. Ladies and gentlemen, we will have an opening remark by the Dean of Faculty of Medicine, Prof. Reviono. To Prof. Reviono, please proceed. Thank you.
Dr. Dionis ya?
Anjay, Profesor.
Belum mulai ya?
Sudah, Prof. Sudah, monggo kalau badhe untuk pembukaannya, Prof. Apakah suaranya masuk nggih, Prof?
No, very little.
Okay. Okay, so it's already start. So yes, Prof. Reviono, you can start to open this event first.
Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. I would like to welcome Honorable Speaker Dr. Caroline Copeland. Nice to meet you. She is from Institute of Pharmaceutical Science, King's College London, United Kingdom. Thank you for willing to share your knowledge in this event. This lecture is our first series of international guest lecture held by Department of Pharmacology, Faculty of Medicine, Universitas Sebelas Maret. Okay, this topic maybe is about the drug-drug interaction. Is an important concern in drug development and post-marketing pharmacovigilance. Drug interaction can result in adverse events or reduction in the therapeutic effect. By hosting this lecture with the topic of lesson learned, Gabapentinoid related deaths in United Kingdom. We wish to encourage students and clinicians to become more aware of drug-drug interaction in aiding clinical decision-making. Well, as Dean of Faculty of Medicine, Universitas Sebelas Maret, I would like to thank you, the speaker, and also committee for preparing this event. I officially declare International Guest Lectures, Lesson Learned, Gabapentinoid related deaths in United Kingdom to begin now. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, thank you, Prof. Reviono. And then next, ladies and gentlemen, we kindly ask all participants in today's Zoom room to turn on the camera for a virtual photo session. We're gonna start from page 1. Maybe please turn on your camera, ladies and gentlemen. Okay, we will take the picture. Okay, thank you. Okay, and then ladies and gentlemen, without further ado, we will continue to our main event, which will be moderated by Dr. Dionisa. To Dr. Dionisa, the time is yours.
Thank you very much, Camila. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. And also good morning for you, Caroline. Thank you for joining us today. So before we're going to the main event, I would like to introduce first our speaker, Dr. Caroline Copeland. So Dr. Caroline Copeland she's a lecturer in pharmaceutical medicines at King's College London. She graduated from the University College London and Imperial College London with the topic of neuropharmacology and neurophysiology of cortical circuits. Then she did her postdoctoral at Imperial College London with the focus on bioengineering system for neuronal physiology network dynamics. She moved to the St. George then University of London and focusing on the neuropharmacology and mathematical modeling for pharmacoepidemiology of drug-related deaths. In 2019, then she continued her career as a lecturer in King's College London. Besides her role as a lecturer, she is also the director of the National Program on the Substance Abuse Death. Also, she has a role in the Home Office Advisory Council for the Misuse of Drugs Novel Psychoactive Substance Subcommittee, and also the Wales National Implementation Board for Drug Poisoning Prevention. She is also one of the head of the research group at King's, which focus on improving healthcare strategies for people who use drugs. Her current projects are developing wearable skin sensor to protect against opioids overdose and also identifying of drug-drug interaction between licensed medicines and illicit substance to prevent adverse events. She also supervised 3 PhD students and more than 40 masters and pharm bachelor students, and also has published over 30 research articles, with the latest publication among them are fatalities associated with gabapentinoids in England, and many more. So let's invite our speaker for today, Dr. Caroline Copeland. She will talk an interesting topic about gabapentinoid related deaths in the United Kingdom. So without further ado, to Dr. Caroline, the time is yours.
Thank you, Dionysa. Okay, can you see my screen?
Yes, perfect.
Great, okay, well, thank you for those introductions. So I'm going to be talking today about gabapentinoid related death, particularly those which have occurred in England, but the mechanism by which they are occurring in England is probably common throughout the world as well. Okay, so first off, I'm going to start by introducing what are the gabapentinoids, because they are a newer class of drug in those available for treatment. So they are gabapentin and pregabalin, and despite their names both having the word GABA in, GABA is of course the major inhibitory neurotransmitter in the central nervous system. And despite them having GABA in the name, and they do have similar structural motifs in this amine group here and this carboxylic acid group here, they have a completely different pharmacology to how GABA works, which we'll be looking at momentarily. So gabapentin was the first to be developed, followed a couple of years later by pregabalin. And they were originally designed to treat epilepsy. And it is for this indication that the two compounds were first trialed in the clinic. However, it was discovered during the trials that actually these drugs were also pretty good at treating neuropathic pain. Now, neuropathic pain is very specifically pain that results from the damage of nerve endings. And it's only for this type of pain that gabapentin and pregabalin are indicated for in the UK. But as we'll see, they've been prescribed for an awful lot of other pain types as well, which is not necessarily a good thing. Finally, they are also now often prescribed in the treatment of anxiety. It's an off-label indication, but it's approved by the NHS here in the UK. So despite their original design in the treatment of epilepsy, very, very few people are prescribed for this indication. Again, for the neuropathic pain, there are people that are prescribed it for this, but there are quite a lot of people that receive them for other pain conditions, which isn't necessarily appropriate. And a lot of people now receive them in the treatment of anxiety. So how do the gabapentinoids work? So as a brief recap on how GABA itself works. So GABA is the major inhibitory neurotransmitter in the brain. And one of their major actions is at the GABA A receptor, which is an ion channel gated receptor, which when it is activated, opens and it allows the flow of negatively charged chloride ions into the cell. By allowing negative charge into the cell, that makes the cell unlikely to be excitable because it's got this high negative charge. So it's probably not going to be firing an action potential. So the inhibitory action of GABA is to induce what we call a hyperpolarization, increased negativity in a cell, making it unlikely to fire an action potential. But as I mentioned, despite the name of the gabapentinoids and having a similar structural motifs to GABA itself, their pharmacology is actually quite different. Now, it's not necessarily fully understood how the gabapentinoids work to exert their effects. But there's a couple that we're pretty sure that they are working by. One of these is their action at voltage-gated calcium channels. So here we've got a presynaptic and a postsynaptic terminal with some vesicles that are releasing neurotransmitter. Now, under normal circumstances, when an action potential arrives in a presynaptic terminal, this activates the voltage-gated calcium channel and it opens these voltage-gated calcium channels. And this huge influx of calcium which occurs as a result, the calcium acts on these vesicles which contain neurotransmitter and stimulate them to start merging with the presynaptic membrane, releasing their concentration of neurotransmitter to act postsynaptically at whichever receptors are going to be here. And one of the ways which the gabapentinoids work is that they block the voltage-gated calcium channels, and therefore they block and inhibit presynaptic vesicle fusion with the membrane and the release of neurotransmitter into the synapse. Now, there's also another mechanism of action where they think that the gabapentinoids can increase the synthesis of GABA itself by acting on the enzyme that converts glutamate to GABA, but which of course will in itself increase inhibition in cells via this mechanism here. But it's thought that the major inhibitory action of the gabapentinoids is through this mechanism described here. So to summarize, the GABA inhibits majority by inhibiting postsynaptic excitability. So it's stopping these cells from firing a further action potential and continuing on the communication. Whereas the gabapentinoids, they are inhibiting the presynaptic neurotransmitter release. So there isn't any chance of even activating this postsynaptic cell in the first place. So in the treatment of epilepsy, when you're trying to reduce excitation, if you're, the gabapentinoids would reduce the release of excitatory neurotransmitter like glutamate. Similarly, if you're trying to reduce pain signals and you're stopping that pain signal from being transmitted across a synapse, it's going to reduce the amount of painful stimuli reaching the central nervous system. So what about gabapentinoid toxicity? So in England, in the recent paper that we published, between 2004 and 2020, there were 3,051 deaths where a gabapentinoid was detected. The 2004 cutoff, the start date, was chosen because that's the first date that there was a death registered in England with a gabapentinoid, which was gabapentin. And I think the first pregabalin death occurred in 2006. And of these 3,051, we had 913 with gabapentin and 2,322 with pregabalin. So there's this huge swing towards the second of these compounds in terms of what looks like their toxicity and association with mortality. Now, interestingly, of these thousands of deaths, there were only 2 deaths where the gabapentinoid was taken alone and was deemed to have caused death. So this raises the question is, are the gabapentinoids actually that toxic? It would suggest that when they're taken alone, they're not really that dangerous because there's hardly any deaths with these drugs alone. So, potentially could it be that there's some withdrawal-induced seizures? And there have been reports of people who only use the gabapentinoids from suffering seizures which can prove fatal. And the mechanism for this is that, we think what the mechanism for this is that in a normal synapse, we've got presynaptic neurotransmitter release activating postsynaptic receptors such as the excitatory glutamate receptors. Now, when gabapentinoids are being used chronically over a period of time, because of this reduction in the amount of neurotransmitter that's released, the body thinks that this is abnormal. And so it's like, well, we aren't getting that much excitatory input. And the way it tries to solve this imbalance that's being induced by the administration of the gabapentinoid is to traffic more glutamate receptors to the postsynaptic membrane. So any small amount of neurotransmitter release that does happen now has a better chance of activating this postsynaptic neuron. However, if you were to be taking a lot of pregabalin or gabapentin over a long period of time, and you've increased the number of postsynaptic glutamate receptors that you've got here, if you were to suddenly stop taking the gabapentinoid, you would end up with a huge amount, well, a normal amount now of neurotransmitter release, but an abnormally huge amount of postsynaptic cell excitation. So you're going to be generating an imbalance in what the normal excitatory inhibitory innervations would be, which can cause epileptic seizures. A similar mechanism we think occurs with people that use chronic alcohol chronically in alcohol abuse. And a similar thing happens there when there is abrupt stopping of alcohol use. Again, because of receptor trafficking there, it can cause seizures that can prove fatal. So whilst this mechanism is interesting and it's something which we're seeing more and more of now as gabapentinoid use becomes more and more chronic, it's certainly not the major mechanism that's causing death. We have 3,049 more deaths that we need to be accounting for here as to how they occurred, because only 2 of them are due to the gabapentinoid alone. And for this, we need to look at a paper that was published in 2017 in the journal Addiction. And in this paper, the authors looked at both users of heroin. So heroin is an illicit opioid here in the UK. And they also did some animal model looking at co-use of morphine, which is an opioid, and one of the gabapentinoids as well. So let's first have a quick look at the opioids and remember what they are and what their pharmacology is, because that's important to understand, to have a look at the potential interaction occurring between the opioids and the gabapentinoids. So the opioids is the term for all drugs which act at the mu kappa and delta opioid receptors. And the term opiates is limited to just those compounds which are naturally occurring in the opium poppy. So opium poppy opioids, of which there are many, morphine, codeine, diamorphine, they are all opiates. They can all be found in the opium poppy, but only those ones are opiates. All the other opioids, which we have, tramadol, oxycodone, they aren't naturally occurring, and so they are opioids, and so the opiates sit within the opioids. So with the opioids, we have natural opiates, we have semi-synthetic opioids, and we have fully synthetic as well. So an example of a natural opiate is morphine, and a semi-synthetic is oxycodone. And we can see here from the structure of morphine that it's just been augmented slightly to create oxycodone. We've had some substitutions in the medicinal chemical structure here. So we've created a new opioid from a naturally occurring opiate. And then we have synthetic opioids like methadone, which is a completely different structure to that of the naturally occurring opiates. And finally, there is this terminology which is used with the opioids with regards to if they are weak or strong opioids. Now, this terminology is a bit confusing, and I'm not sure myself how helpful it is, because to label something as a weak or a strong opioid is looking at their potency at being able to activate the new, particularly opioid receptor. But unfortunately, the term weak and strong to the general public, the first thing that doesn't occur to them is that this is to do with potency and not concentration. If you think about alcoholic drinks, a weak alcoholic drink has alcohol in it. It's a single substance, but it might only have 2 or 3% alcohol, whereas a strong alcoholic drink might have 18 or 20% alcohol. And with alcohol, the compound itself hasn't changed. It's still just as potent. It's just the amount that is there. And a lot of opioid, a proportion of opioid overdose can be attributed to this misunderstanding that with a weak opioid, it means there's not as much there. So you have to take more to feel an effect, when actually it's to do with the potency, and that's a real risk of overdose if that were to happen. So opioid pharmacology, how do these compounds actually produce analgesia? So you have 3 major new opioid receptors, mu, delta, and kappa. And these are all G protein coupled metabotropic receptors, which when they are activated, they do a variety of things. They are GIO coupled, so they are coupled to the G receptor protein signaling cascade intracellularly that inhibits cyclic AMP formation. And by inhibiting cyclic AMP formation, it decreases the voltage-gated calcium channel opening, and it also increases potassium channel opening. So presynaptically, these receptors are also inhibiting neurotransmitter release in a different mechanism to how the gabapentinoids are doing it, but the end result of reduced neurotransmitter release is the same. So both the gabapentinoids and the opioids are inhibiting presynaptic neurotransmitter release. Now, depending upon where these opioid receptors are localized within the central nervous systems and peripheral nervous systems, they do have different effects. And the ones that are most often sought by people who use these drugs are those that act at the new opioid receptor and for the feelings of analgesia, so the feelings of pain relief, and those that abuse these substances and use them recreationally also seek the mood alteration, the feelings of euphoria that can be induced when using opioids. So if their pharmacologies are very similar, why would you take opioids and gabapentinoids together? Why not just take more of your opioid or more of your gabapentinoid? What seems to be the benefit for people that are taking both at the same time? So going back to this paper, they do a lovely set of interviews of people who are heroin users and their recent experience of using gabapentinoids. And I've chosen here just one of the quotes of many that are in the paper, which really sums up the effect that is occurring. And that's that pregabalin was enhancing the feeling of the heroin. And interestingly, this interaction and this effect was not discovered in a lab. It wasn't discovered by any scientists. It was discovered by heroin users in the Bristol area, which is southwest England, found that taking these two drugs together increased the high that could be achieved. And the effect of this is twofold. For the users themselves, it's sort of like a cost-saving activity. If you can take pregabalin, which is fairly cheap in terms of street value, you can reduce the amount of heroin you take at the same time, because the amount of euphoria that can be gained from the same dose of the heroin can be increased if you also take pregabalin. However, opioids are respiratory depressants. And so if you're increasing the effect of the opioid to enhance the euphoria and the feelings that people who use these opioids enjoy, you're also enhancing the risk of respiratory depression, which can lead to complete stopping of breathing and death. So secondly, in this paper, what this research group did was they wanted to investigate this respiratory depression potential in an animal model. And what they discovered was it looks like the gabapentinoids reduced the tolerance developed towards opioids. And this is really dangerous. So if we have a look at this graph here, what you've got on the left-hand side is minute volume. So this is the amount, the volume of air that is breathed in per breath. And so the higher the number here, the more air is getting into the lungs. So if you have a reduced minute level, that's indicative of respiratory depression. And along the bottom here, we just have time. Now, in these animals here, they had been pre-treated with morphine. So they had been given morphine, which is an opioid, several times over the preceding weeks. So they had developed a tolerance to morphine. Now, opioids, a bit like we saw with the gabapentinoids, they induce tolerance. And so it means that if you take these drugs for a long time, to feel the same effect, you have to take increasingly higher doses to achieve this. So here, these animals are on quite a high dose of morphine because they've been pre-treated and they've developed tolerance. And when they're given morphine at a lower dose, their respiratory function is not altered really at all from the control. So we don't have any evidence of respiratory depression. However, in the same animals, when giving the same dose of morphine, but this time also giving pregabalin, we see an immediate and very marked reduction in breathing, down to 50% here. So you've got a 50% reduction in breathing at the same morphine dose, but it's just that the pregabalin has reversed the tolerance. So a dose of the opioid in a person that was previously safe and didn't cause any respiratory depression is now causing considerable respiratory depression because this tolerance was reversed. And this is one of the major mechanisms which we think is occurring when people are taking a gabapentinoid and an opioid together. So if we have a look at the number of deaths which have occurred in England over the past sort of 15 years or so, we can see the first death due to gabapentin in 2004, and the first pregabalin death occurred in 2006. And since about 2012, 2013, there's been a huge increase in the number of deaths where these substances have been detected. In yellow, we've got the number of deaths due to gabapentin. In blue, those due to where pregabalin was detected. And in green, these are where both substances were co-detected at the same time. And what we have in the yellow and the blue lines is the number of prescriptions that were dispensed at the same time in the years that these deaths occurred. And what I'll point out here, and I'll come back to this shortly, is that even though we've had about 1 million more gabapentin prescriptions a year, apart from in 2019 when it crosses over, there were always more pregabalin deaths than there were gabapentin deaths, despite there being fewer prescriptions. So please remember this. We'll come back to the reason why we seem to have fewer pregabalin prescriptions, but more deaths in a moment. So of these 3,049 deaths that we've got left, 92% of them had an opioid co-detected. That is a huge amount of congruity here, a huge amount of cases where we've got both a gabapentinoid and an opioid had been taken and then death occurred. So the mechanism of this interaction between the two compounds causing respiratory depression is likely playing a part in the majority of these deaths which are here. Now, if we look at the source of the gabapentinoid that was detected in the people who died, we can look at whether or not the deceased had been prescribed the gabapentin legitimately through a healthcare professional, or if they had been illicitly procured as street gabapentin or street pregabalin and obtained via drug dealers and other sources. In the database that I run, we do get prescribing data for a lot of people, but it's not always provided. So we do have an unknown source in some cases. If we look here, we can see that in a decent proportion of both gabapentin and pregabalin deaths, the gabapentinoid had actually been prescribed to the deceased legitimately. They hadn't got it illegally. And if you then look at the co-detected opioid that was discovered in toxicology as well, in 25% of these deaths, both the gabapentinoid and the opioid had been co-prescribed. That 25% of deaths is 772 people who died following an opioid and a gabapentinoid being co-prescribed. And this is a big problem. You know, in these 772 cases, the person has taken the drugs that their doctor has said they should be taking. And you can see why both of them would have been prescribed. They both are indicated for the treatment of pain, and people who are in chronic pain, they say that they're looking for pain relief. And unfortunately, there's not that many compounds that are effective for a very long time. And so people resort to using multiple pain medications when it might not be appropriate. So you might have somebody who's on a high dose of morphine to try and control their chronic pain, and then their family doctor, their general practitioner, their GP here in the UK, has gone and then co-prescribed a gabapentinoid. And it's very possible that these people were using these drugs appropriately, they weren't abusing them, but due to this interaction, they were causing death. And there's a considerable amount of work happening here now in the UK to try and reduce the amount of this co-prescribing of these two drugs to people, but it's quite difficult to stop. So why does there appear to be this preference for pregabalin? Why are there so many more deaths due to pregabalin instead of gabapentin, when it's the gabapentin that has been majority prescribed for a lot of the time? And if we have a look at some of the pharmacological properties of the two compounds, it becomes apparent as to why this is the case. So if we have a look, oh, I've put the wrong titles on the wrong side, I'm very sorry. If we have a look at the bioavailability, sorry, it should be pregabalin is 93% and gabapentin is 33 to 66. So pregabalin is much more bioavailable. This one is correct, sorry. The pregabalin is absorbed much more quickly than the gabapentin, and the gabapentin is also rate limited. So you've got higher bioavailability, you've got faster absorption, and you've also got increased affinity. Pregabalin is 6 times more potent at inhibiting those voltage-gated calcium channels than gabapentin is. So altogether, pregabalin is the much more potent of the two gabapentinoid structures, and therefore when it's taken, it's much more likely to induce stronger effects, which in combination with an opioid is leading to increased death. And if we have a look at the concentrations of the two gabapentinoids that are detected in deaths which occurred, in this graph here on the right, we've got the post-mortem blood concentration in milligrams per litre. And for gabapentin, we have quite a wide range of concentrations, particularly in the higher region. Whereas for pregabalin, the concentrations that were detected were on average much lower. And this is a statistically significant difference in the average concentrations between the two compounds. And what this is showing us is that less pregabalin was needed for death to occur than gabapentin. Because the gabapentin is less potent, people would be having to consume more of the gabapentin before it became a toxic effect in combination with that opioid than they would the pregabalin. So this is a much more potent, more dangerous of the two gabapentinoids as a result because of its pharmacology. So what can we do? This is obviously a clear problem, particularly in the UK. So can we control gabapentinoids more strictly? 800 deaths a year is a huge number of deaths occurring. That's nearly 3 deaths that's happening every single day due to these drugs being taken. If you had delivery drivers in the UK who deliver packages, knocking over and killing 3 people a day, there'd be outcry, and driving practices would immediately have to be reviewed because the amount of death that would be occurring would just be unacceptable. So it's sad that we've got so many deaths occurring in the UK due to this drug use, but no real effective way currently has been found to stop this. And if you have a look here in 2019, the gabapentinoids were rescheduled here in the UK. And what a rescheduling means is that they become more controlled. So in 2019, fewer prescriptions were dispensed, and the prescriptions that were dispensed were not as big. They didn't have as many tablets per prescription. So previously, you might have been given 28 tablets in a go, but after 2019, that would have been reduced to 7 to 14. So if you wanted more of the drug, you would have to go back to your GP, to your family doctor, and get more of the drug prescribed. And whilst we do see that there's certainly a flattening of the amount of gabapentin that's being prescribed in 2019, And maybe there's a slight dint here if you squint enough in the amount of pregabalin that was being dispensed. It's certainly not reduced that much, still over 7 million prescriptions being issued in 2020. And so, okay, the scheduling, has it actually reduced the amount of death that's occurring? Well, again, not really. If we take into account that when this analysis was done, we were still expecting to receive a number of deaths in 2020, the trajectory since 2017 is not really affected at all. So we really need in the UK a more effective strategy for dealing with drug use beyond just penalties. The penalties here in the UK are obviously not severe enough to prohibit further drug use from happening. And we see this all over the world. When you have prohibitive drug legislation, the drug use doesn't stop, it just changes in its characteristics. So what we really need to do in the UK is we need to address and treat the reasons why people use drugs. A lot of people who use drugs in the UK come from socially deprived backgrounds where they don't have as good access to education, health services, social services, and they turn to drug use to help with their problems, to alter the reality that they are having to suffer. And so if we could address the cause for them using drugs, as opposed to treating them as criminals for using drugs, that's probably a better strategy to try and reduce drug use. In interviews that are done with people who use drugs, you have a few people who use particularly stimulants and psychedelics recreationally. If they go on a night out clubbing, they might use ecstasy, MDMA or cocaine recreationally. But they're a very small proportion of the people who use drugs for those reasons. A lot of people use drugs to try and escape their reality. And a lot of them cite that they don't enjoy taking drugs. They do it because they feel they have to. So in my personal opinion, continuing to prohibit drug use is not going to actually treat the main cause of this. And we need to look wider. So overall, we need to be looking at the co-prescription of these two compounds, the gabapentinoids and the opioids, and try and reduce that from happening. And then to stop deaths which are related to appropriate clinical use of these problems. And for people who abuse these drugs, we need to be looking just beyond prohibiting their future use. Another interesting concept which has happened due to this interaction is that it's actually possible to use the interaction for good and for benefit. So in the US in particular, we know that there's this opioid epidemic. This is due largely to a compound I showed at the beginning, oxycodone, which was marketed as OxyContin in the US. And it was marketed as a non-addictive opioid. The data that they used was very, I don't think it was appropriate. They used data from people who had had burns, and they had taken a single dose of oxycodone, and they were then surveyed to see if they were addicted to oxycodone after one dose. And it's very difficult to become addicted to anything after one dose. So the number of people addicted to oxycodone were, of course, incredibly small. So it was from this particular study that then oxycodone was marketed across the states as non-addictive. A lot of people took it, and a lot of people became addicted to the drugs because they are opioids. And so we now have this opioid epidemic in the US, where you've got a huge amount of death occurring and a huge amount of opioid misuse. And a lot of this opioid misuse and death occurs because people become tolerant to opioids. They have to take more and more opioids in order to feel the same effect until it gets to the point of respiratory depression. So a question raised is, if you were to start by giving people both a gabapentinoid and an opioid at a much lower dose, because the gabapentinoid reverses and stops tolerance to opioids developing, if you were to give them both in the same formulation, could you stop opioid tolerance from happening? Could you therefore give these people opioids more safely if it was given together with a gabapentinoid? Or would this be a dangerous thing to do? I'm not entirely sure, but there is work happening looking at a dual opioid gabapentinoid formulation to try and reduce opioid use as a result. Okay, so thank you very much for listening. I hope that that was informative for you. If you'd like to look more at some of the data that we produced looking at the fatalities in England, this is the paper that was recently published earlier this year. And this is my email address if you have any questions. Thank you.
Thank you very much, Caroline, for your speak. Yes, so it's really a wonderful topic that like I never like try to think to, I mean, we used to combine gabapentinoid and opioids, but it's like the drug-drug interaction and resulting in the, like, maybe I read like some respiratory depression also like usual. So it's kind of like a new topic that we also have to be aware. So, okay, let's continue, move on. After this, we will have a question and answer, Q&A. So for audience, if there is any question, you can like maybe raise your hand first. Okay, so yes, Dr. Siatmi.
Okay, thank you. Good afternoon, Professor Caroline Copeland. Thank you very much. And actually, I want to little bit give information about the use of gabapentin in Indonesia, especially in my area that I know. I'm a GP, so sometimes I visited by patient that already treated by neurologists, and from there I know that is it now quite common for prescribing gabapentin, pregabalin, something like that to manage pain related to muscular problem or a neurological problem. So my question is concerning with the use of the increased use of gabapentin, pregabalin, and something like that. How to evaluate the toxicity of the drug when it is given to patient with for long-term therapy?
So this is a big problem in pain management in general, is that the drugs that we have, either, you know, if they work, they only tend to work for a short amount of time before they have to start taking increasing doses. And the same, you know, it happens with the gabapentinoids as well. So there's not, I don't really have an answer, I'm afraid, and it's very frustrating because these patients are suffering. They are experiencing awful pain conditions, but we don't really have the appropriate tools to treat it. So we're using what we have, which is, okay, opioids, but they should really not be used chronically for chronic pain. They have limited efficacy. And the same goes for the gabapentinoids. Now, unfortunately, there's a lot of pressure from patients. They want to be treated. They want to have their pain taken away, which is understandable. Like, we would all want that. So, you know, using the drugs that are here is often what happens because there aren't really that many alternatives that are available. So I appreciate your question, but I'm afraid there's not much of an answer in terms of alternatives. But we just know that this one's not very safe as well.
Are there any kind of clinical examinations, like laboratory examination, to indicate early toxicity of the gabapentin use on patient? Does in UK it is applied to examine any hematology parameter or something like that for patient?
So the toxicity of the gabapentinoids alone seems to be very, very low. You have to have incredibly high levels of these drugs to cause any toxicity. And as much as having a huge dose that might be causing itself respiratory depression, you've also got sort of renal and liver injury that can occur from just a very high volume of drug that they're having to process. But in terms of their intrinsic toxicity, it seems to be very, very low. The levels of drug that we see in the people that have taken just pregabalin or gabapentin and died is absolutely huge amounts. I think therapeutic levels of these drugs is somewhere between sort of 10 to 20 milligrams per litre in blood concentration. And the people that have died with these drugs alone likely had several hundred milligrams per litre at the time that they died. So these huge amounts. So on their own, the toxicity seems to be very low, which we see with just those 2 deaths out of the over 3,000. But it's when that they're combined with the opioids that their toxicity becomes apparent in the interaction.
Okay, thank you very much. So you mean that in a normal dose, is it quite safe to use the gabapentinoid for long-term therapy?
On its own, without an opioid, it would certainly be safer. How long it would be effective for, I think, would vary from person to person. There are reports that people have to take increasing doses, and it's in people who take it for a long time. And it's in these people who, when they stop taking these very large amounts of the drugs, are then experiencing these seizures. And these withdrawal-induced seizures are being seen more and more here in the UK now, because these drugs were only introduced onto the market in the early 2000s. So they're quite new compounds in that regard in comparison to benzodiazepines, which are used very similarly. And so the amount of misuse that's occurring has been a lot less because the use has had to grow. So the toxicity of them at a low dose, if a patient is on it for a very long time, I'd probably say is a low risk. But if they're having to titrate up and up and up, the risk then is if they were to stop taking it, that they could have some withdrawal-induced seizures.
Okay, thank you very much, Professor Caroline Copeland.
Thank you.
Thank you, Dr. Suyatmi. It's really interesting. I mean, like, if it's like gabapentin alone, it's safe, but if you combine with opioids, it might become a really big problem. Okay, so next question maybe from others. Oh, I think also there's a question in the chat. Okay, so there's some question that's from some students who are kind of shy to ask you. So first of all, the first question is how to evaluate the toxicity of gabapentinoid. Okay, this is the question I think it's being answered already. The second one is, this is the same one. The third question is, I wonder what less fatal effects than death of gabapentinoid opioid co-medication have been mostly reported, and if they are dose dependent.
So less fatal effects of gabapentinoid opioid co-use has been people collapsing as if they were to have a fatal overdose, but it hasn't been quite severe enough to cause death. So you do have a lot of hospital presentations as well where there was less severe overdose, which does occur. But it is this majority respiratory depression effect over any cardiac effects, which might be occurring. And if they are dose dependent, yes. So what I haven't shown is some recent work where we've looked at the concentration of the opioid that was co-detected with the gabapentinoid. So I showed you that pregabalin is more potent than gabapentin, and therefore less pregabalin can prove fatal, and more gabapentin is needed to prove fatal. And we've looked in those cases at the amount of tramadol and the amount of oxycodone, which was co-detected. And in cases where a gabapentinoid was present, you do have less opioid present. So there is certainly a drug-drug interaction occurring, which is reducing the toxicity threshold. So less of each drug is needed to prove fatal when taken together than either drug alone.
Okay, thank you very much, Dr. Caroline. I think that will answer the question. And then, is there any other questions? I think it's, yeah, okay. You can go, Marilla.
Okay, thank you, Dr. Yunita. Maybe, apakah suara saya terdengar sih? Iya. Okay, thank you, Dr. Caroline Copeland, for your information. And I want to ask you something about the impact of pandemic COVID with this current trend. If there is an impact or might impact for the future trend related to gabapentin and opioid medication. Thank you.
Okay, I might try to restate it again. So is there any effect or impact of the current trend of COVID-19 with these trends with the gabapentinoid related death, or maybe like in the future it will be like increasing or something like that? Because I think it's rescheduled in 2019, and after that it's still increasing, and then COVID happens. So I mean, like if there's any impact or like in the further.
So we're doing some work at the moment looking at the effect of COVID-19 on drug use. We haven't looked specifically at the gabapentinoids yet, but we have looked at changes in opioid use. And in the UK, because of the lockdowns and the restriction of movement that we had, there was a lot less street opioids available. People who were dealing drugs, if they were out on the street, they stuck out and the police could notice them. So there was much less street opioids available. But at the same time, there was more methadone available. So methadone is used to treat people with opioid use disorder. It's used as a substitute for heroin, and they try to wean people off using the methadone. And in the UK, normally the majority of people have what's called daily supervised consumption, where they have to go every day to the pharmacy and they get a very small amount of methadone that's coloured green, and they have to be witnessed to drink it and then show that their teeth are stained green, that they've actually taken their methadone and not hiding and stockpiling it for later use or to sell it. But during COVID, these daily supervised consumption stopped because it was seen that these people who use heroin tend to have very poor health. Quite a lot of them suffer from COPD. They would have to get to the pharmacy, which wasn't really promoting the stay-at-home message, which we had here in the UK. And there was also risk that they might not get their opioid as well, because if the pharmacy staff were sick and the pharmacy closed, there could have been problems in them getting access to their opioid. So a lot of people were transferred to take-home methadone. And this was 2 week supplies, sometimes a litre of methadone in one go. that these people were given. And there was a lot of overdoses in people who were prescribed methadone. And there was also a very much bigger increase in deaths where people who were not prescribed methadone died. And that's because there was, we think, fewer street opioids available, because there were fewer dealers giving out heroin, that more people went and bought methadone from the people that had been prescribed it. So this prescribed methadone was diverted. So in terms of how that might affect the gabapentinoid effect, I imagine a bit like with the street heroin, street gabapentinoid availability probably decreased as well a little bit. So we might actually be seeing fewer deaths occurring in 2020 with the interaction, that then in 2021 and 2022 might be increasing again as the lockdowns have stopped, more street opioids are available, and more gabapentinoids are as well.
Okay, thank you very much. I think it's also answered the question. Is there any other question again for the participants? If not, I might like have one more question. So, I mean, like, I know that this is like the drug-drug interaction and stuff. So what kind of like, how will you mitigate it? I mean, you talk about they have been like rescheduling from the government and stuff. How like we maybe like as the pharmacovigilance people or something like that, how can we like try to manage this or like try to monitor this? Like how to detect the signal of it and stuff and how to manage it?
Well, so the big problem is not, as we've discussed, it's not their intrinsic toxicity on their own. It's this co-prescribing with the opioids, which is and the co-use with opioids, which is the bigger problem. So from a pharmacovigilance perspective, here in the UK, our GPs, they have an electronic healthcare system, which when you try and prescribe a drug, if you're trying to prescribe a second drug, which has an interaction, a little warning sign appears on the computer screen and says, warning, don't prescribe these two drugs together. Now, unfortunately, a lot of these warning signs appear a lot of the time, and the prescribing doctors get a bit annoyed because it's like, well, I can't prescribe anything together because everything's got a drug-drug interaction. And sometimes they get ignored and get co-prescribed. So you can have these sort of safety systems in place, but if they can be overridden, I don't know what else you could do. I mean, I think that the gabapentinoids could be scheduled up again. I think they are Schedule 3 at the moment. So on the same level as tramadol and codeine. But they could become Schedule 2, which is the same level as morphine. So there could be more control. I don't think that's really going to have an effect. You know, the scheduling from 4 to 3 didn't do much. So I can't imagine doing that is going to help. And I think there needs to be a greater holistic treatment of people that use these drugs, as opposed to just criminalizing drug use.
Okay, thank you very much. That's really answering, including the warning system that like, yeah, I mean, it's really helping for us, but at the same time, we cannot prescribe anything also. Okay, thank you very much, Caroline. Is there any other questions? Okay, I think that's all. So thank you very much, Caroline, once again for your sharing your knowledge and everything. And for that, I would like to share the certificate for you first. Okay. So yeah, this is just like a certificate for us as a speaker for this first webinar, International Guest Lecture. So thank you very much. I will send it to you later on the email.
Thank you very much.
No worries at all. Okay. Someone maybe can take the picture of it first. Okay, thank you very much. So, okay. So this is like the end of the topic. Like I would like to conclude it for a bit that actually the current trends is there's like a co-prescription because they want to like reduce the use of opioids, but at the same time, it gives us a new problem again for the drug-drug interaction. So of course, us as the clinicians should take care of this, should take aware if we really need to prescribe it or not, or if there any option at that. And also if find something like this, maybe like can report the system and stuff. So there will be another management in the future. So thank you again for all of the participants. Thank you again for Dr. Caroline Copeland for here for sharing our knowledge, for sharing your knowledge, for giving us a new topic for us to learn. And also thank you also for all the participants for here. It's really nice to have these sessions. So thanks you back. I will give back this mic to our MC, Camila. The time is yours.
Okay, thank you. That was an interesting topic to learn. Thank you once again for our speaker, Dr. Caroline Copeland, for sharing her knowledge with us. Finally, we are in the end of this event. Once again, I would like to express our gratitude for our wonderful speaker today, Dr. Caroline Copeland. Thank you. Also, thank you for all participants in both Zoom and YouTube for your enthusiasm today. We hope to see you again in our next event. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Caroline. Have a great weekend.
Thanks. Bye.
Bye.
Thank you.
Thanks.